My name is Dr. Darin Larson. I specialize in hip and knee replacement here at Iowa Ortho. Going to be a little change from the title of the webinar today. So as opposed to a true kind of top 10, where's my pain coming from? We'll kind of differentiate between hip, knee, and back pain. Kind of some different things to look for and what might be causing my pain. So please feel free to utilize our chat function today. We'll try to get to those questions towards the end of the webinar today. We'll kind of go from there. So a brief overview today. We'll kind of go through the real quick snapshot of the human nervous system, talk a little bit about hip pain, knee pain, and then back pain, and then we'll open it up for any questions after that. So to start off with the human nervous system here, this is kind of a real simplified version of the nervous system. This doesn't include a lot of the smaller nerves, things like that. But the reason I put this in here is to illustrate that your pain can radiate or essentially be referred from multiple different sources. So with me specializing in knee and hip replacement, I see a lot of folks who may have knee pain that might actually feel like, or excuse me, that might be more coming from the hip, might be coming from the low back. You can see here where the spinal cord goes down, and then the nerves come out of the spinal cord from that location and basically supply sensation to everything from the low back to the hip to the knee down to the foot. So something to kind of keep in mind there, where pain may be radiating from one spot, although it might be felt in a different location. So joint pain in particular, you can have multiple potential sources of pain within a single joint, and we'll kind of get to that as well as we break down the hip and the knee here in a little bit. Although we do tend to generalize this as hip pain or knee pain, can get multiple different areas within those specific joints that may cause issues for folks. So hip pain, important to identify the source of the pain. Is this more of a deep-seated groin pain? Is this more of a lateral or outside of the hip pain? Or is this pain that kind of radiates down to the foot? All three of those can potentially be coming from three different areas. Groin pain is typically more related to issues within the actual hip joint itself or within the hip capsule. That is typically something that we see more with arthritis patients or other what we call intra-articular or within the joint issues. Lateral or outside of the hip pain, coming more from over top of this bony prominence on the outside of the hip. If everybody's able to see my mouse or my pointer here, that may be more of a bursitis type of issue, which we'll get to as well. Pain radiating down to the foot, that may be more secondary to nerve issues in the low back or nerve irritation from the low back that might be referred down the length of the extremity. And it's important to identify the source of the pain because there are different treatments for these different types of pain. So something where we want to make sure that we have the correct diagnosis before going through a treatment option. I don't like to offer people hip or knee replacements if we can't be sure that that's where that pain is coming from. So what are some different sources of hip pain? Osteoarthritis, or the typical kind of wear and tear arthritis that you hear of, or old age arthritis. Arthritis does not tend to be discriminatory in age. I've seen folks in their 30s with arthritis. I've seen folks in their 80s and 90s with arthritis. It doesn't discriminate based on age. There can be multiple different factors or causes for arthritis, or this kind of the wear and tear or osteoarthritis. We know that there's a genetic component. So if you've had family members that have had arthritis, you're a little bit more prone to getting that. We know that there is just kind of that general wear and tear. So heavy laborers, or if you're up on your feet a lot, that may also play a role. Obesity also increases the risk for arthritis in the knees and hips, or anything that you weight bear on a daily basis. For every pound of body weight, it's roughly 4 pounds of pressure on your joints. So obesity can certainly play a role there. With rheumatoid arthritis, that is more of a systemic inflammatory disease. So tend to have more kind of inflammation throughout the body with rheumatoid arthritis. Bursitis is essentially inflammation of a bursa, or a small fluid-filled sac. Bursa are normal structures that you have over your elbows, over your knees, over your hips. You actually have a couple different areas in your hips that have bursa. Sometimes those can get inflamed and cause that bursitis. Fractures or breaks in the bone, typically secondary to trauma. So we won't really go through that a whole lot in this specific talk, but that may be another source for pain. Infection, again, not something that we'll focus on a whole lot, but maybe something that could potentially be causing some pain. That's more of an acute issue, more kind of red, swollen types of issues there. And then, of course, pain referred from the back that can be felt in the hip. So hip osteoarthritis. So again, this is more of that wear and tear arthritis causing a kind of deep-seated groin and or buttock pain. This can be associated with more of a chronic aching pain, can have difficulty sleeping at night, trouble sitting down for long periods of time, whether that's a long car ride or, sitting at a desk for a long period of time. This may radiate down the front of the thigh, but typically doesn't go past the knee. I see some folks who have knee pain, but it actually is coming from the hip. So you may not always feel that groin pain. It might be felt somewhere else. So I always like to evaluate hips in folks that have knee pain, especially if the knee x-rays are looking fairly benign. And you can commonly have a fairly limited range of motion as far as the hip goes, specifically with rotation of that hip. This is kind of a nice illustration over here on the right side of the screen, where we can see with this arthritis, we've started to lose some of that normal cartilage that we're born with, get more of this underlying bone. It can be more of a rough, uneven surface. So you see that destroyed cartilage here, you see this narrow joint space, and you also see bone spurs. Bone spurs are the body's natural response to arthritis, where they try to spread that force out over a much larger area. Those bone spurs are typically what causes the limited range of motion, so difficulty putting shoes and socks on, or doing other kind of normal day-to-day activities. Treatment options for osteoarthritis. I'm a big proponent for exhausting everything non-surgical before we have that replacement discussion, or that hip replacement discussion. Usually recommend starting with anti-inflammatory medications, things like ibuprofen, Aleve, meloxicam, diclofenac, something along those lines. Sometimes we can consider doing steroid injections into the hip for both diagnostic and therapeutic purposes, meaning if we are unsure of, is that pain truly coming from the hip joint, those injections may help us say the injection worked, so we can kind of direct our focus towards the hip, or no, the injection did not work, even just for a couple of hours or a couple of days, in which case, we further evaluate the low back or other potential sources for pain from the hip. Activity modification is another potential thing, or some physical therapy. And then kind of the end stage treatment for severe hip arthritis is a hip replacement. Rheumatoid arthritis, similar treatment options to osteoarthritis. However, that is usually directed more by a rheumatologist as far as any systemic medications. They've done a lot of advances in the last several years where a lot of folks who have rheumatoid arthritis can now be controlled with medications before really getting to severe cartilage degeneration. End stage treatment for rheumatoid arthritis for the joints is the same thing. It's either a knee replacement or hip replacement. But I'll kind of skip over those treatments for the rheumatoid arthritis, because again, that's more driven by a rheumatologist. Bursitis, again, a bursa is a small fluid-filled sac that acts like a cushion. These can get inflamed for whatever reason, whether that's overuse, decreased use, trauma, so a direct fall or hit to that hip or knee. You can also get this from an altered walking pattern. So if you have injuries to your knees, your ankles, your feet on one side, that may throw off your walking pattern, might make it difficult, and potentially lead to muscle weakness. So those muscles that go kind of above that bursa can get a little weaker. And there's a thick band of tissue along the outside of the leg called the IT band that can get sort of tight and cause some issues as well. So typically what these treatments involve are anti-inflammatory medications, physical therapy, either at home or some dedicated formal physical therapy where you visit with a physical therapist 2 to 3 times a week for several weeks to try to strengthen up those muscles and stretch that IT band out. An alternative is a steroid injection directly into those bursa. I usually like to wait for at least 4 to 6 weeks after trying the physical therapy to see if we can make some improvement there. I'd say a pretty large percentage of folks will get better with just the exercises alone. That way we can avoid an injection. But that is something that we can consider down the road if we're still having issues with the bursa. And again, this is more, so trochanteric bursitis or greater trochanteric bursa is more on the outside of the hip. So that may be causing more of kind of a lateral or outside of the hip pain. This iliopsoas bursa is more in the front of the hip. So that may be causing more issues with hip flexion or activities like going up and down stairs. Something that, can do an injection into that bursa as well. That is typically done under x-ray guidance. These trochanteric bursa injections are on the outside of the hip, typically done in the clinic. Moving on to knee pain, again, some various causes for knee pain to consider. Again, the osteoarthritis or the general wear and tear of the knee, something that I can see very commonly. Rheumatoid arthritis as well, so similar with the hip, more of a systemic inflammatory disease, something that can be directed a lot of times by a rheumatologist to help prevent the very severe arthritis. But again, the end stage treatment for rheumatoid arthritis is very similar to osteoarthritis with a joint replacement. Meniscus tear, we'll be getting into that a little bit more in depth here in just a moment. Ligament sprains or other injuries, fractures around the knee or breaks around the bone, and then the potential from pain being referred from the hip and or back. It is very possible to have pain coming from multiple different sources. So whether that's the hip and the knee, the hip and the back, or the knee, hip, and the back, kind of all of the above. So it's important to, not only differentiate that pain, but realize that there may be multiple sources where you might be feeling different things from. So knee osteoarthritis, again, this is more of a chronic aching pain causing a lot of stiffness when sitting for long periods of time, or pain with normal day-to-day activities, walking, going up and down stairs, things like that. Again, the causes can be multifactorial, so genetics, trauma to the knee in the past, previous surgery, wear and tear, or obesity. This is a nice x-ray on the right here, where when we're born, we all have cartilage on the end of our long bones. We can't see cartilage on an x-ray, but we can see this dark space that represents that, as evidenced here on the left side of that image. On the right side, as that cartilage tends to wear away, we see less and less of that joint space. We see it's much more narrow over on that right side of the screen. We've lost a lot of that dark joint space that goes in there. So that is severe osteoarthritis of the knee. So treatments for the knee, very similar to the hip as well. Anti-inflammatory medications are kind of the first line, so ibuprofen, meloxicam, Aleve, things of that nature. Physical therapy to work on strengthening some of the muscles around the knee to help provide some stability. We can also try either steroid injections or viscosupplementation or gel injections in the knee. Bracing is an option. Genicular nerve blocks are another potential option for folks who are trying to avoid surgery at all costs or hold off surgery for as long as possible. Whereas opposed to injecting a medication into the knee joint, we have a couple of pain specialists here at Iowa Ortho who target the nerves around the knee as opposed to the actual knee joint itself, as another potential non-surgical option. And then kind of once we've exhausted all those non-surgical options, that's when we have the discussion for a knee replacement or a total knee replacement. Again, here's another good diagram where on the left side, we can see some good cartilage, both on the femur or the thigh bone side, as well as the tibia or the shin bone side. We see normal meniscus right here. So meniscus or a meniscus is a different type of cartilage than what we have on the ends of the bones, provides a bit of a cushion to the knee. Again, we'll get to that in just a moment here. On the right side of the screen, similar to that hip, we see a lot of these bone spurs around here. We see this cartilage loss where we lose kind of that smooth, shiny surface on the end of the bone to get more of that underlying bone under the cartilage, and then narrowing of that joint space or loss of that cartilage as evidenced on x-ray. Meniscus tears, we'll kind of come back to this picture here in just a moment as well. So again, the meniscus is a fibrocartilaginous structure that provides a little more of a cushion that lives in between the femur, the thigh bone, as well as the tibia or the shin bone. You can see different varieties of tears over here on the left. This is more of an acute type of tear. On the right side, this is what we call more of a degenerative type of tear. And it's important to differentiate those here. So not all meniscus tears are created equal, meaning that, you know, not every meniscus tear is something that needs a knee scope to take care of that or try to repair or remove that. So an acute meniscus tear, something from like a sports injury or a twisting injury, something that you think of with like a 20-year-old football player getting in a meniscus tear, different from a degenerative meniscus tear, which is what we typically see with arthritis. So you may still have pain while twisting from arthritis, but it may not be that type of meniscus tear that may need anything. So what happens with arthritis is, we'll go back to this picture here. Once we start to lose that smooth cartilage on the end of the bone, that joint becomes more narrow, that meniscus essentially gets pinched in between the two rough surfaces of that bone, and it can kind of start to tear or fray that meniscus, as opposed to somebody who has a meniscus tear with good looking cartilage on the end of the bone, where that's something that you may typically repair or remove a part of that meniscus. So again, an acute tear over here on the left, kind of this degenerative fraying type of tear over here on the right. So not every meniscus tear requires an MRI or surgical treatment. That is something that I would recommend visiting with your orthopedic surgeon about to see if that is something that is necessary. People with arthritis can get symptomatic meniscus tears, but I would say more common than not, it's not something that will require surgical treatment. So when to consider an MRI or surgery for a suspected meniscus tear, if you're younger or have little to no evidence of arthritis on x-ray, or if you are having what we call mechanical symptoms, which are catching and locking sensations in the knee where it feels like the knee gets stuck. You may have some kind of catching and popping sensations with arthritis in general, but the meniscus tears typically cause more of a locking sensation where it kind of feels like you have to shake that leg to get the knee to unlock, or it can be a very painful popping sort of sensation. So again, something that I would recommend visiting with your orthopedic surgeon about, as far as, you know, is this something that would require an MRI, or is this something where we direct that treatment more towards arthritis? I would say the vast majority of folks who have severe arthritis in the knee will have a meniscus tear, but that meniscus tear, again, does not always require surgical treatment in and of itself. The reason I caution folks for, you know, getting an MRI if we know that you have severe arthritis is that, you know, if you have severe arthritis, it's already evidenced on an x-ray, and we get an MRI for some reason and it shows there's a meniscus tear. If you get that meniscus removed, that can actually cause your arthritis to progress more rapidly and actually cause more pain. Not only that, but if we talk knee replacement down the road, having a previous knee scope increases your risk for infection or other complications after a knee replacement, particularly within the first 6 to 9 months after having a knee scope, if we were to go forward with a knee replacement. Lastly, I did want to touch on back pain a little bit as being a potential source of hip pain or knee pain, whether that's from a disc herniation, as we can see here on this image. This is an MRI or a portion of an MRI where we see a little bit of the lumbar spine or the low spine. In between the bony structures here, we see these disc spaces. These discs can sometimes extrude or herniate back into the nerves or cause irritation with the nerves. May also see arthritis in the low back, or can get some low back pain that's more due to the muscles that surround the spine. This might cause more kind of midline low back pain, or this may cause pain that radiates all the way down the foot. So this is something where, if we see folks who have maybe some mild arthritis on x-ray, but the pain is more kind of radiating down to the foot, this is something where I may have some folks see one of my spine partners to further evaluate the low back before we do, any aggressive treatment for the knees or the hips, just to make sure we're not treating something that we don't need to be treating. So with the back, either rest or anti-inflammatory medications, physical therapy, certain types of injections into the low back, or potentially surgery. And I would kind of defer that discussion to one of my partners if that was something that was necessary as far as the spine goes. So in conclusion, it's important to identify the source of pain, which helps direct treatment, whether that's injections, surgery, or, do we need to evaluate other potential areas, whether that's the hip or the back, as opposed to the knee. And then also important to recognize that you can have pain from multiple different sources at the same time. So the hip and the knee, hip and the back, hip, knee, and back, or potential multiple sources from pain from one joint. So for example, some people may have severe hip arthritis with coexisting bursitis. It's just a matter of, trying to differentiate the different types of pain and then directing treatment for each of those things.